If you or someone you care for takes Losartan for high blood pressure, there are 9 side effects you probably haven't been taught to watch for, and one of them can show up slowly, quietly, and then land you in the emergency room. Today, I'm going to walk you through those 9 side effects, why they happen, who is most at risk, the red flags that mean get help now, and practical steps you and your clinician can use to reduce risk. This is evidence-first information, not a scare piece. Losartan helps many people control blood pressure and protect the kidneys, but like any medicine, it has trade-offs. If you want clear, practical guidance, stay with me. And if you value reliable, clinically grounded health information, subscribe now. Let's start with a very simple primer so the rest makes sense. Losartan is an angiotensin II receptor blocker, an ARB. To picture why that matters, imagine a faucet that turns on a chain of signals called the renin-angiotensin-aldosterone system, or RAS. When RAS is active, blood vessels tighten, the body holds on to salt and water, and the kidneys are prompted to adjust filtration. Losartan blocks one receptor in that chain, so blood vessels relax, blood pressure drops, and the kidneys see a different internal signal about salt and fluid. That helpful change is why Losartan lowers blood pressure and, in many cases, protects the kidneys in people with diabetes. But because the RAS system influences blood pressure, potassium balance, kidney blood flow, and even how your liver and blood cells behave, blocking it can lead to a predictable set of downstream effects. Understanding those effects, the mechanism, helps you know what to watch for and when to call for help. We'll treat each side effect the same way: a plain definition, a one-sentence why Losartan can cause it, how commonly it shows up in clinical experience, who's at higher risk, the usual timing after starting or changing the dose, the red flags that need urgent attention, and practical monitoring and mitigation steps you can raise with your clinician. I'll also give a short, anonymized vignette to make the abstract feel real, because numbers matter, but stories stick. Side effect 1, dizziness and orthostatic hypotension, the stand up slowly problem. Dizziness when you stand up, lightheadedness, or fainting are commonly reported complaints among older adults taking blood pressure medicines, and Losartan is no exception. Why? By dilating blood vessels and lowering systemic vascular resistance, Losartan reduces the pressure available to push blood to the brain when you stand. In older adults whose blood vessels or reflexes are less responsive, that drop can produce symptoms. In the language clinicians use, this is orthostatic hypotension, when blood pressure falls enough on standing to cause symptoms. How common is it? In clinical trials and real-world practice, symptomatic drops in blood pressure are a well-recognized side effect of ARBs and other blood pressure medicines. Older adults, especially those also taking diuretics, other blood pressure agents, or medications that affect balance, sedatives, some antidepressants, are more likely to notice it. Dehydration, recent vomiting or diarrhea, and hot weather also increase the chance. Typical timeline: dizziness often appears within days to weeks after starting Losartan or after increasing the dose, but it can occur any time if volume status changes, for example, after a night of heavy sweating or if a new diuretic is started. Red flags: fainting that leads to injury, confusion, chest pain, shortness of breath, or a prolonged loss of consciousness are reasons to seek emergency care. Even repeated near faints or falls should prompt a same-day call to the prescribing clinician. Falls in older adults have a high cost in fractures and loss of independence. Practical mitigation and monitoring. A few simple measures dramatically reduce risk. Stand up slowly from sitting or lying down. Pause for a moment before walking. Ensure adequate hydration if your clinician agrees it's safe for your heart and kidneys. Review all medications with your pharmacist or doctor. Stopping or lowering a diuretic or a second blood pressure agent may be the right move. If dizziness starts within a few days of a dose change, call your prescriber. They may want to check blood pressure, supine and standing, review medications, and consider a small dose adjustment. Home blood pressure checks, sitting and standing, for a few days can provide valuable data. Vignette: Margaret, 78, had been stable on a thiazide diuretic for years. Her doctor added Losartan because her blood pressure readings crept up. 2 days later, she felt lightheaded getting out of bed and nearly fell. Her daughter brought her in. Standing blood pressure dropped significantly from sitting. After holding the diuretic for a week and adjusting the Losartan dose, the dizziness resolved. Visual cue suggestion: show a short timeline graphic of start/up titrate to days to weeks to monitor standing BP with a silhouette of a person rising slowly. Side effect 2, headache. Many people report headaches after starting a new blood pressure medicine. Losartan's vasodilatory effect, relaxing blood vessels, can lead to transient headaches as the body adapts to different pressures and flow. For most people, headaches are mild and short-lived. How common is it? Headache is listed among the more frequently reported adverse events in trials, but it varies widely among individuals. Importantly, persistent or severe headaches that are new and different from previous patterns deserve prompt evaluation. Who's at higher risk? People with a prior history of migraines, those who suddenly lower caffeine intake at the same time as starting a medication, or patients experiencing rapid blood pressure drops are more likely to have symptomatic headaches. Timeline: often within hours to days of the first dose or after a dose increase. For many, headaches settle within several days as the body compensates. Red flags: a sudden, severe, worst headache of life, new neurological deficit, weakness, speech changes, imbalance, fever, or neck stiffness should trigger immediate emergency evaluation. Also, headaches accompanied by very low blood pressure or fainting need urgent care. Practical steps: simple analgesia approved by your clinician, consistent hydration, and avoiding abrupt changes in caffeine can help. If headaches persist beyond a week or are worsening, speak to your prescriber. They may reduce the dose or try a different agent. Vignette: Harold, 67, started Losartan and noticed a mild throbbing headache the first 2 days. He kept a pain diary and it faded by day 5. His clinician reassured him and advised continuing the current dose while monitoring. Side effect 3, fatigue, weakness, and low energy. Feeling unusually tired or weak on a blood pressure medicine is a common complaint among older adults and can have multiple causes. Losartan can lower systemic blood pressure sufficiently that some people notice less energy. Additionally, electrolyte changes like hyperkalemia, elevated potassium, or changes in kidney function can cause weakness. Mechanism in one sentence: by reducing blood pressure and altering kidney handling of salt and potassium, Losartan can indirectly contribute to symptoms of fatigue and muscle weakness when those physiological changes are significant. Incidence and context: fatigue is reported with ARBs, but is nonspecific. Aging, sleep problems, anemia, thyroid disease, and many other drugs can also cause it. That's why a careful evaluation is key, rather than assuming the medicine is solely to blame. Who's at higher risk? Older adults with multiple chronic conditions, those on multiple medicines, polypharmacy, people with anemia or thyroid disease, and patients who develop electrolyte abnormalities or reduced kidney function after starting Losartan. Also, those with recent dose increases or combination therapy with other agents that lower blood pressure. Timeline: fatigue may start within days to weeks and sometimes appears more slowly as other physiological changes accumulate. Red flags: sudden severe muscle weakness, difficulty breathing, chest pain, or progressive decline in ability to perform daily tasks require urgent evaluation. If weakness is associated with palpitations or irregular heartbeat, seek care right away. It could be a sign of significant electrolyte imbalance. Practical mitigation and monitoring: baseline blood tests such as a complete blood count (CBC), serum electrolytes including potassium, and serum creatinine/eGFR can help identify reversible causes. If you or a loved one notice new or worsening fatigue after starting Losartan, schedule a prompt check with the clinician. Simple interventions, correcting anemia, addressing sleep issues, review of other medications, often fix the problem without stopping Losartan. Vignette: Rosa, 73, started Losartan and felt increasingly washed out over a month. Blood tests showed her hemoglobin was low and her potassium mildly high. After treating the anemia and adjusting a potassium supplement prescribed by another provider, her energy returned. Side effect 4: hyperkalemia, elevated potassium. This is one of the side effects that clinicians worry about first with ARBs. Potassium is critical for heart and muscle function. Small increases can be silent, larger increases can cause dangerous heart rhythm disturbances. Why Losartan can cause it? ARBs reduce aldosterone signaling downstream in RAS. Aldosterone normally tells the kidneys to excrete potassium. When that signal is blunted, potassium tends to rise. How common and how to interpret it? In otherwise healthy patients with normal kidney function who are taking Losartan alone, clinically significant hyperkalemia is relatively uncommon. However, the risk rises when other risk factors are present: chronic kidney disease, diabetes, older age, concurrent use of potassium-sparing diuretics like spironolactone, ACE inhibitors, high-dose NSAIDs, or oral potassium supplements. In real-world clinic populations with multiple comorbidities, hyperkalemia is a frequent reason clinicians check labs and adjust therapy. Who's at higher risk? People with a reduced eGFR, kidney function, those taking multiple medications that increase potassium, those on a low-sodium diet with high potassium foods emphasized, and anyone with diabetes-related kidney disease. Typical timeline: potassium can rise quickly within days to weeks of starting an ARB or adding another interacting medicine, but it may also climb gradually, especially if kidney function declines slowly. Red flags: muscle weakness, tremor, palpitations, chest pain, lightheadedness, or syncope require immediate attention. Severe hyperkalemia can cause abnormal heart rhythms visible on an ECG and can be life-threatening. Practical monitoring and mitigation. Common clinical practice is to check serum potassium and creatinine before starting Losartan, and again within 1 to 2 weeks after initiation or a dose change. If you have chronic kidney disease or are taking drugs that raise potassium, more frequent monitoring is common. Avoid adding potassium supplements or salt substitutes containing potassium unless your clinician approves. If your potassium is mildly elevated, dietary counseling, stopping or tapering potassium-raising drugs, and temporary dose adjustments may control levels. Severe elevations warrant urgent treatment. Vignette: James, 80, had stage 3 chronic kidney disease and was started on Losartan. His potassium went from normal to mildly elevated on a lab check 2 weeks later. Because he was also on spironolactone, his clinician paused the spironolactone and increased lab surveillance. Potassium normalized and his blood pressure remained controlled. Visual cue suggestion: show a simple potassium meter with color zones: green, normal; yellow, mildly elevated, call clinician; red, danger signs; and a list of common interacting drugs. Side effect 5: kidney function changes, rising creatinine and reduced eGFR. Losartan can change the way the kidneys filter blood. For many people, especially those with diabetes and protein in the urine, ARBs provide long-term kidney protection by reducing pressure inside the kidney filters. But in certain situations, particularly when kidney blood flow depends on angiotensin II-mediated constriction of a kidney artery, for example in bilateral renal artery stenosis or in low circulating volume, blocking those receptors can cause a drop in the filtration rate and a rise in serum creatinine. Mechanism in one sentence: by altering intrarenal blood flow dynamics through RAAS blockade, Losartan can transiently reduce glomerular filtration pressure, producing a rise in serum creatinine in vulnerable patients. Incidence and context: a small, often acceptable rise in creatinine after starting an RB is expected in some patients and can be reversible. Larger rises or progressive deterioration indicate a problem and require prompt reassessment. Clinicians often accept a modest creatinine increase, for example up to a certain percentage from baseline, while monitoring because long-term benefits can outweigh a small and stable rise. However, a large or continuing increase is concerning. Who's at higher risk? People with volume depletion, dehydration, recent use of diuretics, renal artery stenosis, advanced heart failure, or baseline reduced kidney function. The combination of an RB with an ACE inhibitor increases renal risk and is generally avoided except in carefully monitored specialist settings. Typical timeline. Changes are often detectable within days to a couple of weeks after starting or increasing the dose, but progressive declines can unfold over months if a new interacting medication or illness, vomiting, diarrhea, infection reduces circulating volume. Red flags. Significant rise in creatinine on recent labs, sudden reduction in urine output, fluid overload with shortness of breath, or worsening swelling may all reflect clinically important kidney function changes. Contact your clinician promptly. If you have very low urine output or signs of fluid overload and shortness of breath, seek urgent evaluation. Practical steps. Check baseline creatinine or eGFR before starting Losartan. Recheck within 1 to 2 weeks after initiation or dose adjustment, and more often if you have reduced kidney function or are taking other interacting medications. If you become dehydrated because of illness or you're told to take fewer fluids, call your clinician about holding medications temporarily, but do not stop medications on your own without guidance. Medication reconciliation is vital. NSAIDs and certain diuretics can amplify kidney risk. Your clinician may adjust doses or substitute safer options. Vignette. Ernest, 75, was started on Losartan and had a routine lab 2 weeks later that showed his creatinine had risen compared with his baseline. He had also recently started an over-the-counter NSAID for back pain. His clinician stopped the NSAID, reassessed volume status, and repeated the lab in a week. Creatinine trended back toward baseline, and his Losartan was continued at a lower dose. Side effect 6. First dose hypotension and exaggerated blood pressure drops on dose increases. Some people experience a pronounced drop in blood pressure the first time they take Losartan, particularly if they are on other blood pressure medicines or diuretics, or are volume depleted. This first dose phenomenon is usually short-lived, but can be dangerous if it causes falls or syncope. Why it happens? The initial blockade of angiotensin II receptors can remove a key compensatory mechanism that maintained vascular tone, so the first exposure causes a more marked vasodilation than later steady-state doses in some individuals. How common? First dose hypotension is a recognized but not universal effect. Clinicians typically mitigate it by starting with a low dose, adjusting other medications, or spacing dosing times. Risk factors: concurrent diuretics, ACE inhibitors, older age, recent dehydration, and poor oral intake. Taking the first dose at night may reduce the chance of symptomatic hypotension. Timeline: typically occurs within hours of the first dose or after a dose increase. Red flags: fainting, injury from a fall, prolonged confusion, or inability to stand are reasons to seek immediate care. Even if you don't faint, repeated lightheadedness merits same-day contact with your clinician. Mitigation: start at a low dose if you're older or taking multiple blood pressure agents. Consider giving the first dose at bedtime and ensure adequate hydration. Keep a blood pressure log for the first week after any change and share it with your clinician. Vignette: Dorothy, 82, took her first Losartan tablet in the morning while still on her diuretic. She felt dizzy and sat down quickly, avoiding a fall. Her clinician recommended taking Losartan at bedtime and temporarily reducing the diuretic. This prevented further episodes. At this point, we've covered 5 of the 9 items that often get missed. You should already have a clearer sense of how Losartan's action in the RAS system produces predictable downstream effects, and how certain risk enhancers like kidney disease, diuretics, potassium supplements, NSAIDs, and dehydration interact to raise the chance of trouble. We've also reinforced a few patterns you can act on now: baseline labs, potassium and creatinine, home monitoring after a dose change, medication reconciliation to uncover hidden interactions, and thoughtful advice about standing slowly and staying hydrated. Before we move on to the remaining side effects, some of which are less common but potentially serious, let's pause and highlight a few practice points that apply across the board. First, never stop Losartan abruptly without consulting your prescriber. Stopping can cause blood pressure rebound and other harms. Instead, if you suspect a medication-related problem, call your clinician for an evaluation that may include blood tests and temporary adjustments. Second, medication lists are frequently incomplete in the record. Bring every pill, supplement, and over-the-counter medication to appointments. Many interactions involve things you might not think of: potassium supplements, salt substitutes, herbal products, or frequent NSAID use for arthritis pain. Third, labs are not optional if you have risk factors. Checking potassium and creatinine at baseline and within a week or two after starting or changing the dose is routine clinical practice in many settings. Frequency after that depends on kidney function and comorbid conditions. Now, before I go further, a short practical note about what your doctor or pharmacist may do. They will often use the same toolkit we've described: check basic labs, review other medications, consider a lower starting dose, possibly stagger dosing times, for example, take low-dose diuretics in the morning and Losartan at night, and give specific advice for what to do during intercurrent illness, vomiting, diarrhea, poor intake that can increase risk. As we continue, keep in mind these mitigation strategies. They apply to many of the remaining side effects we'll discuss. Side effect 7. Upper respiratory symptoms and cough, less common than with ACE inhibitors, but possible. Cough is a famous side effect of ACE inhibitors. ARBs, like Losartan, typically produce less cough overall. Still, some patients report new or persistent cough after starting an ARB. The mechanism is less direct than for ACE inhibitors, and the incidence is lower, but it's worth noting because a new cough in an older adult can have multiple causes and should be evaluated. Why it can happen? Losartan's effect on bradykinin is much less than ACE inhibitors, which is why cough is less frequent. But individual sensitivity and coincidental respiratory infections can lead patients to link cough to their medication. How common? Overall, cough is much more frequent with ACE inhibitors than with ARBs. With Losartan, the occurrence is lower but not zero. If a cough starts after a medication change and persists, it should be evaluated. Who's at higher risk? Those with a prior history of ACE inhibitor cough, people with chronic lung disease, or those with concurrent upper respiratory infections. Timeline: may begin days to weeks after starting medication or be temporally unrelated. Red flags: cough with blood, high fever, severe shortness of breath, or coughing that interferes with swallowing or breathing should prompt urgent evaluation. Practical steps: document onset and characteristics of the cough, rule out infections or heart-related causes, and discuss with your clinician whether a trial off the medication or switch to another class is warranted. Vignette: Sylvia, 69, developed a persistent dry cough after starting an ACE inhibitor years ago and switched to Losartan without recurrence. 2 months after starting Losartan, she had a transient cough during a cold, but it resolved. Her clinician emphasized that persistent or blood-streaked coughs always need evaluation. Side effect 8. Anemia, lower red blood cell counts, and fatigue. Anemia is sometimes observed in patients on ARBs. The mechanism isn't usually a direct toxic effect on the bone marrow. More often, it reflects underlying chronic disease, kidney disease reducing erythropoietin production, or blood loss detected during the workup of new symptoms. Losartan itself has been associated with small changes in hemoglobin in some studies. Mechanism: by altering kidney function in susceptible individuals, ARBs can indirectly affect erythropoietin signaling and red blood cell production. Other contributors include chronic disease and drug interactions. Incidence and context: clinically significant anemia attributable solely to Losartan is uncommon, but a fall in hemoglobin after starting a medication should prompt evaluation. In older adults, even modest drops in hemoglobin can produce notable fatigue and reduced function. Who's at higher risk? Patients with chronic kidney disease, nutritional deficiencies, chronic inflammatory conditions, or concurrent medications that increase bleeding risk, anticoagulants, antiplatelets. Timeline. Anemia may be detected weeks to months after starting therapy, although an acute drop suggests bleeding or other causes and needs immediate investigation. In older adults, even modest drops in hemoglobin can produce notable fatigue and reduced function. Who's at higher risk? Patients with chronic kidney disease, nutritional deficiencies, chronic inflammatory conditions, or concurrent medications that increase bleeding risk, anticoagulants, antiplatelets. Timeline. Anemia may be detected weeks to months after starting therapy, although an acute drop suggests bleeding or other causes and needs immediate investigation. Red flags. Shortness of breath at rest, chest pain, lightheadedness, rapid heartbeat, or syncope require urgent assessment. Signs of active bleeding, black or bloody stools, frank bleeding should be evaluated promptly. Practical steps. Check a baseline CBC in patients with risk factors and recheck if fatigue or other symptoms develop. Treat underlying causes, iron deficiency, occult bleeding, or worsening kidney disease rather than reflexively stopping Losartan. Vignette. Miguel, 76, reported gradual fatigue after a medication change. His CBC showed lower hemoglobin. Further evaluation revealed an iron deficiency from a small gastrointestinal bleed. Addressing the bleeding and giving iron improved his energy. Losartan was not the primary culprit, but the timing prompted the workup. Side effect 9. Rare but serious liver injury. Severe liver injury related to Losartan is rare, but when it occurs, it can be serious. That makes it important to know what to watch for, even if most people will never experience it. Mechanism in one sentence. Idiosyncratic drug reactions can occasionally impair liver cells or bioflow, producing elevations in liver enzymes and, in rare cases, jaundice or liver dysfunction. How common? Clinically significant liver injury with Losartan is uncommon in clinical trials and post-marketing surveillance, but because the consequences can be severe, clinicians remain vigilant. Who's at higher risk? People with pre-existing liver disease, heavy alcohol use, or those taking other potentially hepatotoxic medications. Genetic factors and unpredictable idiosyncratic reactions underlie most cases. Timeline. When it occurs, liver enzyme elevations or symptoms typically appear within weeks to a few months after starting or changing the medication, but timing can vary. Red flags. Yellowing of the skin or eyes, dark urine, persistent nausea and vomiting, severe abdominal pain, unexplained bleeding or easy bruising, or mental confusion suggest significant liver injury and need immediate medical attention. Practical steps. Baseline liver function tests, LFTs, may be reasonable in patients with known liver disease or concerning symptoms, and clinicians will often recheck LFTs if a patient reports symptoms suggestive of liver injury. If LFTs rise significantly or if jaundice occurs, the medication is usually stopped and the patient evaluated urgently. Vignette. Helen, 71, with a history of fatty liver disease, began Losartan. 2 months later, she noticed yellowing of her eyes and dark urine. Urgent testing showed markedly elevated liver enzymes. Losartan was stopped and she was managed in hospital. Fortunately, the injury was reversible with supportive care. We've now walked through all 9 side effects that are commonly overlooked by seniors and caregivers: dizziness/orthostatic hypotension, headache, fatigue, weakness, hyperkalemia, kidney function changes, first dose hypotension, upper respiratory symptoms/cough, anemia, and rare but serious liver injury. Each of these follows logically from Losartan's action on ROS or from common interactions with other medicines and comorbidities. Before I pause here, I want to pull several threads together that apply to all 9 concerns and that you can act on immediately. First, labs to know. The most relevant blood tests are serum potassium and serum creatinine eGFR to monitor kidney function, a baseline and a repeat within 1 to 2 weeks after starting or changing dose is common clinical practice, with more frequent checks if you have reduced kidney function. In patients with anemia symptoms or risk factors, a CBC is helpful. If there's concern about liver injury, check liver function tests, ALT, AST, bilirubin. Your clinician will tailor the schedule to your specific risk profile. Second, medicines that amplify risk. Combining Losartan with ACE inhibitors is generally avoided because the combination increases the risk of kidney injury and hyperkalemia. Potassium-sparing diuretics and supplements, some NSAIDs, and certain herbal products can raise potassium or impair kidney function. A medication reconciliation with your pharmacist is one of the highest value safety steps you can take. Third, what to do if you get sick. For any acute illness with vomiting, diarrhea, poor oral intake, or fever, call your clinician. You may be advised to hold blood pressure medicines temporarily until you're rehydrated and labs are checked. Fourth, fall prevention. Because orthostatic symptoms and dizziness can cause falls, consider strategies such as removing tripping hazards, using night lights, and having a plan if you feel faint. Sit down immediately. At this midpoint, there are practical next steps for you or a caregiver right now. Make a short checklist. List every medication and supplement you take. Schedule or request baseline labs if you haven't had them recently. Keep a small notebook or phone photo log of blood pressure readings, both sitting and standing, for a few days after any dose change. And call your prescriber promptly for any red flag symptoms we covered: fainting, chest pain, shortness of breath, jaundice, sudden severe muscle weakness, or signs of significant bleeding. We've laid the groundwork and covered the 9 headline side effects with their mechanisms and what to watch for. In the next section, I will examine real-world incidence data and how to interpret trial numbers versus clinical practice, walk through the most common drug-drug interactions in detail with specific examples you can use at the pharmacy, and offer a step-by-step monitoring schedule tailored to different risk profiles. For example, an otherwise healthy 60-year-old versus an 80-year-old with stage 3 CKD and diabetes. I'll also give you printable language to bring to your clinician, exact questions and lab orders to request, and a rapid response checklist for what to do in the moment if one of the red flags appear. For now, if any of the symptoms we discussed are present or you're unsure about your current monitoring plan, make that call to your clinician. Keep that medication list handy. Medications, supplements, and even NSAIDs from the pharmacy can silently change your risk profile. And remember, do not stop Losartan abruptly without consulting the prescriber. Instead, use the channels we described to get a safe, monitored adjustment. Next, let's pause on the numbers, because knowing what the studies say and what they leave out changes how you act on this information. Clinical trials versus real life, what to expect. Randomized clinical trials give us the cleanest way to compare drugs, but they don't always reflect the patients you see in everyday life. Trials typically enroll people who meet strict criteria: fewer other illnesses, stable kidney function, and careful monitoring. That tends to make side effect rates look lower than they will among older adults living with multiple conditions, taking several medicines, or recovering from acute illness. Post-marketing reports and observational studies capture the messy reality. People on Losartan in the community often have combinations of risk factors: diabetes, impaired kidney function, diuretics, and occasional dehydration that raise the chance of an adverse event. Another important distinction is relative risk versus absolute risk. A study might say Losartan reduced a risk by a percentage compared with placebo or another drug. That sounds impressive, but what matters to you is the absolute difference in the chance that you or your family member will experience the benefit or harm. For example, a small relative increase in a rare event can still be rare for an individual, while a modest absolute benefit for a common disease such as high blood pressure can be very meaningful. When you review study claims, ask, what is the actual change in chance for someone like me? And look for absolute numbers or the number needed to treat, NNT, and number needed to harm if those are reported. Finally, timing matters. Many side effects appear early, within days to weeks of starting or changing a dose, and are reversible when detected. Others develop slowly. That's why baseline labs and early follow-up are a cornerstone of safe care. They let clinicians find early signals and act before a minor problem becomes an emergency. A practical, evidence-aware lens. When I summarize the literature for patients and caregivers, I use 3 practical filters: who was studied, how big the risk signal is in absolute terms, and whether the risk is modifiable by monitoring or by changing other medicines. For Losartan, the signals we discussed fall into those categories. Some, like mild headache or transient dizziness, are common but often self-limited. Others, like hyperkalemia or significant kidney injury, are less common in isolation but move from manageable to dangerous when other risk factors are present. That's why the next sections focus on interactions, concrete monitoring plans, and exactly what to say to your prescriber. Drug-drug interactions and risk multipliers, the usual suspects. One of the biggest drivers of adverse events with Losartan is the presence of other medicines. Here are the interactions that most often change risk, how they work, and what to watch for. 1. ACE inhibitors, e.g. lisinopril, enalapril. Why it matters. Combining an ARB and an ACE inhibitor increases the chance of kidney dysfunction and hyperkalemia. This combination is rarely used outside specialist care because the harms often outweigh incremental benefits. What to watch for. Rising creatinine/eGFR and increasing potassium. If you see both together after a change, contact your clinician. 2. Potassium-sparing diuretics and mineralocorticoid receptor antagonists, e.g. spironolactone, eplerenone, amiloride. Why it matters. These drugs reduce urinary potassium excretion, so when added to Losartan, they commonly elevate potassium. What to watch for. Muscle weakness, palpitations, ECG changes if severe. Many clinicians will avoid combining these drugs unless there's a compelling reason and frequent lab checks are in place. 3. Potassium supplements and salt substitutes. Why it matters. Over-the-counter potassium or salt substitutes can push potassium into the risky range, especially in older adults with diminished kidney function. What to watch for. Ask every patient whether they use any supplement or salt substitute. It's a surprisingly common hidden source of potassium. 4. Non-steroidal anti-inflammatory drugs, NSAIDs, e.g. ibuprofen, naproxen, and some analgesics. Why it matters. NSAIDs constrict blood vessels in the kidney that normally help maintain filtration, especially when ROS is blocked. The combination of an NSAID plus Losartan, and especially a diuretic, can provoke acute kidney injury. What to watch for. Rising creatinine, reduced urine output, swelling, or new shortness of breath. Avoid regular NSAID use without discussing alternatives for pain control. 5. Trimethoprim-containing antibiotics and some antivirals. Why it matters. Certain antibiotics can impair kidney potassium handling and increase serum potassium when combined with ARBs. What to watch for. Clinicians often advise a lab check if a course of such antibiotics becomes necessary while on Losartan. 6. Lithium. Why it matters. ARBs can increase lithium levels. Toxicity risk rises quickly because lithium has a narrow safety margin. What to watch for. Tremor, severe nausea, confusion. If you're on lithium, coordinate closely with psychiatry or your prescribing clinician before starting Losartan. 7. Heparin and other agents that can reduce aldosterone. Why it matters. Reduced aldosterone function raises potassium. The combination can be additive. What to watch for. Unexplained potassium rises on labs. Polypharmacy and frailty. Beyond named drug interactions, the cumulative effect of multiple medicines, polypharmacy, is a major driver of adverse events in older adults. Blood pressure drugs plus diuretics, sedatives that increase fall risk, and over-the-counter remedies add up. Frailty amplifies problems. A small blood pressure drop that would be nothing in a younger person can cause a fall and a fracture in a frailer older adult. Medication reconciliation with a pharmacist or primary clinician is one of the highest value safety steps you can take. Interpreting lab abnormalities in context. A single lab value rarely tells the whole story. A mild potassium elevation, for instance, can stem from a lab draw technique, a recent supplement, or a real shift in kidney handling. What matters is trend and symptoms. Clinicians look at the whole picture: how much potassium rose, whether creatinine moved in parallel, whether there are ECG changes or muscular symptoms, and whether a new medicine or illness explains the change. Monitoring schedules tailored to common scenarios. Below are example monitoring plans presented as common clinical practice, not strict rules. Your clinician will individualize them. Scenario A: otherwise healthy 60-year-old starting Losartan for hypertension. Baseline labs: serum potassium and serum creatinine/eGFR. Follow-up labs: check potassium and creatinine within 1 to 2 weeks after starting or after a dose change. Ongoing: if stable, check periodically at routine visits, for example, every 6 to 12 months, or sooner if new medications or illness occur. Symptom monitoring: home BP checks for the first week after change, and note any dizziness, persistent headache, or muscle weakness. Scenario B: 75-year-old on a thiazide diuretic with intermittent NSAID use. Baseline labs: potassium, creatinine/eGFR, baseline blood pressure log. Follow-up labs: within 1 week and again at 2 to 4 weeks after start or dose change, sooner if NSAIDs are used frequently. Medication review: consider reducing or stopping the diuretic temporarily when initiating Losartan, or spacing doses, diuretic in the morning, Losartan at night, per clinician judgment. Education: avoid regular NSAID use and check for OTC supplements high in potassium. Scenario C: 80-year-old with stage 3 CKD and diabetes on spironolactone. Baseline labs: potassium, creatinine/eGFR, CBC, LFTs if liver disease risk factors exist. Follow-up labs: check potassium and creatinine within 3 to 7 days of starting or after dose change, then again at 1 to 2 weeks, and frequent monitoring, weekly to monthly until stable. Frequency depends on kidney function and whether spironolactone or other interacting drugs remain. Medication plan: strong consideration to pause or adjust spironolactone at initiation. Discuss alternative potassium-lowering strategies or closer surveillance. Safety net: provide explicit instructions on when to present to urgent care for rapid response flags. See rapid response checklist below. Scenario D: patient taking lithium or with significant liver disease. Baseline labs: lithium level or LFTs as appropriate, plus potassium and creatinine. Follow-up labs: very close monitoring coordinated with the specialty prescriber, example psychiatry for lithium. Coordination: we emphasize communication between prescribing clinicians. Changes in one specialty often require adjustments elsewhere. Printable language to bring to your clinician or pharmacist. Here are concise, practical phrases you can read or show at an appointment. Printing these and handing them to the prescriber can reduce miscommunication. I'm starting Losartan, Cozar. Can we get baseline potassium and serum creatinine/eGFR today and repeat them within 1 to 2 weeks after the first dose or a dose change? I'm currently on list all medicines and supplements. Which of these increase my risk with Losartan? Should any be adjusted or stopped? If my potassium is elevated but under a certain threshold, what is your plan? Will you call me to reduce or pause any medicine? If I feel dizzy or faint after starting Losartan, should I sit and measure my blood pressure and call the clinic that same day? For someone my age and kidney function, what monitoring schedule do you recommend, and who will order the labs so I don't miss them? Please document in the chart any plan for what to do during an acute illness: vomiting, diarrhea, poor intake. Should I hold Losartan temporarily? Clinical staff can use the following lab orders when appropriate: serum potassium, serum creatinine with calculated eGFR, basic metabolic panel, BMP, complete blood count if fatigue or anemia suspected, and liver function tests, ALT, AST, bilirubin, if there are liver disease risks or symptoms. Ask your clinician to include the rationale in the visit note so labs are easy to get without repeated explanations. Rapid response checklist: what to do now if red flags appear. These steps are designed to be practical and immediate. If you're unsure, err on the side of seeking care. Emergency red flags: call emergency services or go to the nearest emergency room right away. Chest pain, pressure, or squeezing that could be heart-related. Sudden severe shortness of breath or difficulty breathing. Loss of consciousness, prolonged fainting, a fall with head injury, or ongoing confusion. Signs of severe hyperkalemia suspected with sudden profound muscle weakness, inability to stand or collapse. Signs of significant liver injury, jaundice, yellow eyes or skin, dark urine, persistent vomiting, severe abdominal pain, or bleeding or bruising that's new and unexplained. Urgent same-day contact with prescriber or urgent care recommended. Repeated fainting episodes or near faints even without injury. New palpitations or a sensation of very fast or irregular heartbeat. Moderate symptomatic hyperkalemia signs, muscle weakness, tingling without collapse. A marked rise in creatinine on a lab you've just had, your clinician may ask you to come in that day. New jaundice symptoms that are not yet severe, pending instruction. Actions to take in the moment for non-emergency but concerning symptoms. If you feel dizzy when standing, sit or lie down immediately. If possible, measure blood pressure sitting and standing and record the numbers. Report them to your clinician. If you have a mild, persistent cough, headache that does not improve, or increasing fatigue, book a same-day appointment or phone visit to review. If you're taking a new medication, including OTC drugs or supplements, and you develop any of the symptoms we discussed, stop the new agent only if a clinician advised you to. Otherwise, call first so they can advise monitoring or testing. What to do while waiting for help. Bring a list of medicines and supplements to every visit. A photo on your phone is fine. Take notes on symptoms, onset, and any recent medication changes. Avoid taking more than the recommended dose of any OTC analgesic without checking, especially NSAIDs. If directed to go to urgent care or the ER, bring a family member or caregiver if possible, and share the medication list and recent lab results. Everyday practical risk reduction steps you can implement. These are low-burden measures that meaningfully lower risk. 1. Medication reconciliation. Bring everything you take, prescription, OTC, and supplements, to your pharmacist or clinician visit. Highlight potassium supplements and salt substitutes, NSAIDs, herbal remedies, and topical agents if you use them frequently. 2. Hydration and illness plan. If you're unwell with vomiting, diarrhea, or poor oral intake, call your clinician early. Many clinicians advise pausing certain medicines during the acute phase of dehydration, but only when told to do so. Don't stop medication on your own without instruction. 3. Dose timing and fall prevention. If you're on a diuretic and starting Losartan, ask about spacing doses, diuretic in the morning, Losartan at night, and consider taking the first dose at bedtime to reduce first dose hypotension. Remove tripping hazards, use good lighting at night, and have a chair nearby to sit immediately if you feel faint. 4. Home monitoring. Home blood pressure checks can be valuable. For a few days after starting Losartan or changing the dose, measure blood pressure sitting and standing once or twice daily and record the values. Share them with your clinician. 5. Nutrition and supplement caution. Avoid adding potassium-rich supplements or salt substitutes without clinician approval. If you have diabetes or CKD, ask a dietitian about balancing nutrition and potassium intake safely. 6. Communication between clinicians. If you see multiple specialists, cardiology, nephrology, endocrinology, psychiatry, ask for a single clinician to coordinate medication changes or for a brief letter summarizing medication reconciliation. ARB starts are a common time for miscommunication. Explicit coordination lowers risk. A quick visual checklist to keep on the fridge. Medication list photo saved on phone and a printed copy in the wallet. Baseline labs: potassium, creatinine/eGFR, CBC if risk, LFTs if risk. Early follow-up labs within 1 to 2 weeks after start or dose change. Home BP log for 3 to 7 days after change, sitting and standing measurements. Avoid NSAIDs and potassium supplements until clinician clears them. Call prescriber for fainting, chest pain, severe shortness of breath, jaundice, or sudden severe weakness. Interpreting lab changes, examples, and physician thought process. Consider 2 short scenarios that illustrate how clinicians interpret lab trends. Scenario: mild potassium rise from 4.4 to 4.9 millimoles per liter. For many patients, this is still within a close to normal range and may be from diet, a lab draw variation, or early ROS effect. The clinician will often repeat the test, review medications and diet, and consider small adjustments rather than stopping Losartan. Scenario: potassium rises from 4.4 to 6.0 millimoles. That level is high enough to demand prompt action. Clinicians will assess symptoms, check an ECG for rhythm changes, review medications for interactions, e.g. spironolactone, trimethoprim, and treat hyperkalemia promptly if needed. This may require temporary hospitalization or urgent outpatient treatment depending on findings. Why many patients still benefit from Losartan? It's important to keep perspective. For many older adults, Losartan provides valuable blood pressure control that reduces the risk of stroke, heart attack, and worsening kidney disease. In people with diabetes and protein in their urine, ARBs are a cornerstone of therapy because they can slow progression of kidney damage over time. The decision to use Losartan is always a balance. The risk of untreated or poorly controlled hypertension is substantial, and the known benefits of ROS blockade are supported by decades of research. The goal of this video has been to help you tilt that balance towards safety by knowing which side effects to watch for, how to monitor, and when to seek help. Closing the loop: how to act after watching this. If this video raised questions for you or someone you care for, here is a simple plan to follow in the next week. 1. Gather your medication list, include prescriptions, OTC drugs, supplements, and topical agents. Take a photo and print a copy. 2. Call your clinician or pharmacist and ask whether you need baseline labs, potassium and creatinine/eGFR if you haven't had them recently, and request a plan for repeat testing within 1 to 2 weeks after any start or dose change. 3. Start a brief blood pressure diary. For 3 days after any dose change, measure sitting and standing BP once in the morning and once in the evening. Bring that log to your visit. 4. Avoid starting any new over-the-counter supplement or NSAID without checking. If you need short-term pain relief, ask your clinician or pharmacist for safer options. 5. Print the rapid response section of this video or save it on your phone so you know which symptoms require emergency care and which require same-day contact with your clinician. 6. If you have an upcoming appointment, bring the printable clinician language we covered and ask explicitly about monitoring cadence and medication reconciliation. Production notes you might see on the screen. On-screen lower thirds for lab names. Baseline labs commonly ordered: potassium, serum creatinine, eGFR, CBC if anemia, LFTs if liver disease. Source: PubMed, NIH, Clinical Guidelines. Links in description. Visual timeline for follow-up labs. Start: 3 to 7 days, clinical judgment, 1 to 2 weeks, periodic. Pop-up checklist for interacting drugs with icons, spirolactone, ACE inhibitor bottle, NSAID pill bottle, potassium supplement jar, lithium vial. A printable card graphic titled What to Ask Your Clinician About Losartan with the exact phrases to use. Final balanced summary. Losartan is a valuable medicine for many older adults. It lowers blood pressure and can protect the kidneys in people with diabetes. But its effect on the ROS system means certain predictable side effects can occur: dizziness and orthostatic hypotension, headache, fatigue, hyperkalemia, changes in kidney function, first-dose hypotension, respiratory symptoms, anemia, and, rarely, serious liver injury. For most people, these are manageable with good monitoring, baseline labs, early follow-up after starting or changing dose, medication reconciliation, hydration guidance, and a clear plan for what to do during acute illness. The single most effective thing you can do for safety is to ensure good communication between you, your pharmacist, and your prescriber. Bring a full medication list, ask for the baseline labs and the early follow-up, and know the red flags that require urgent care. What to do next? Brief checklist. Don't stop Losartan on your own. Call your clinician to discuss any concerns. Get baseline potassium and creatinine, eGFR, if you haven't had them recently. Keep a short home BP and symptom log after any medication change. Review all medicines with your pharmacist, especially supplements and OTC drugs. Seek immediate care for chest pain, severe shortness of breath, sudden collapse, severe weakness, or jaundice. If this video helped you or someone you care for, please share it with a friend or family member on blood pressure medicine and talk to your clinician about the labs and monitoring we discussed. For a list of the peer-reviewed sources and clinical guidelines that inform this guidance, check the description. I've linked reviews and journal articles, PubMed, NIH, NHNN, and specialty journals so you or your clinician can review the evidence in detail.
Thank you for watching. Stay informed, stay safe, and reach out to your healthcare team with any questions about Losartan or your medication plan.